Hey everyone, Ryan here, and welcome back to our Orthodontics series. In the next two videos, we're going to delve into the topic of biomechanics. Biomechanics is the combination of the words biology and mechanics. So our first video will be on the biology of tooth movement. The second video will be on the mechanics involved. Orthodontic tooth movement refers to traversal of a tooth within and through alveolar bone. This biological process is all about the periodontal ligament and the bone. Step number one is you apply force to a tooth, typically via a bracket and wires. Step two, the PDL is stressed as a result of that force. On the compression side, the PDL is going to undergo a cascade of events that results in upregulated osteoclasts, which destroy bone. On the tension side, the PDL undergoes a separate cascade of events that result in upregulated osteoblasts, which create bone. So this results in resorption on the compression side and apposition on the tension side. So the tooth socket itself shifts over. The bone is remodeling in such a way that enables the tooth, as step 4, to freely move along with the shifting bony socket. When orthodontic force is applied in this way, there are two separate biological scenarios that can occur depending on whether the force is heavy or light. So our first consideration is with force magnitude. Is the force being applied less than or equal to 100 grams, or is it greater than 100 grams, just as a ballpark measurement? So we have light force or heavy force. We'll start with light force. So within seconds of that force being applied, the periodontal ligament's blood vessels are distorted. On the compression side, they will be partially compressed, and they'll be partially dilated on the tension side. The patient does not experience any immediate pain associated with that light force. Within minutes, with those blood vessels having been distorted, the blood flow is altered and oxygen and carbon dioxide levels will change. This change in oxygen tension will trigger inflammatory mediators like prostaglandins and rank L to be released. Within hours, we're going to have first messengers like parathyroid hormone and calcitonin, and then second messengers like cyclic AMP being released and increasing in levels, which results in cell differentiation within that PDL. So this initial light force sparked a bunch of signal cascades. Within 2 days, osteoclasts are now recruited and begin the process of frontal resorption from the bony socket. So frontal resorption refers to a steady attack by these osteoclasts on the outer surface of the bone. That's the lamina dura that's directly adjacent to the tooth surface. And these osteoclasts create these craters that are called Howship's lacunae. Within 3 to 5 days, the tooth actually begins to move as this lamina dura, or outer layer of bone, is being pushed back and resorbed by those osteoclasts. And then for 7 to 14 days, this process will continue and continue on as long as that force remains smooth, light, and continuous. Now we have a different story for heavy force. So for heavy forces, within seconds, those blood vessels are not just distorted, they're completely occluded or shut off. They're totally blocked off, and that patient will feel immediate pain and discomfort from that crushing pressure. Within minutes, blood flow is cut off completely on the compression side, and the PDL in that area is literally suffocating. Within hours, the cells in the compressed PDL area die, and that's called sterile necrosis, because this was cell death not caused by any particular pathogen. That dead region of PDL becomes what is called hyalinized PDL because it looks kind of like hyaline cartilage with a bunch of dead cells. Now, if we skip down to 3 to 5 days, this sterile necrosis signals to nearby osteoclasts in the bone marrow that's underlying the lamina dura, because there are no longer any viable osteoclasts in the periodontal ligament because all this area is dead. So it has to recruit from the nearest source, which is the bone marrow. So this is called undermining resorption because bone is removed from underneath until that lamina dura has been collapsed. So those osteoclasts have to eat away from the inside until all of that block of bone has been removed. That process of undermining resorption finally finishes in about 7 to 14 days, and then the tooth is able to move, but it's able to move a relatively far distance since all of that block of bone has been removed from the compression side. So as a graphical summary, we have time in days on the x-axis and distance of tooth movement in millimeters on the y-axis. So as time progresses, the tooth is moving, but it moves very differently depending on the amount of force applied. For light force, that's causing frontal or direct resorption. That's a steady movement of the tooth as the lamina dura is eaten away. Heavy force causes undermining or indirect resorption. And we have this undesirable lag period of about 7 to 14 days until that lamina dura finally collapses, and then the tooth moves a relatively large distance. Now, while the ultimate amount of tooth movement is pretty similar between the two different types of resorption, light is certainly preferable because we get steady movement and the patient doesn't experience as much pain and discomfort. All right, so that's all about force magnitude. Now let's talk about force distribution. So both the amount of force delivered to a tooth and the area of the PDL over which that force is distributed are important in determining the ultimate biologic effect. So this formula, force divided by area equals pressure, is used to describe that this is the force applied by some appliance. This is the area that force is being applied to, and then there's some amount of pressure. In other words, every periodontal ligament has an ideal pressure that stimulates cellular activity without totally occluding those blood vessels. There's some X amount of pressure that puts the PDL at its sweet spot. So depending on the type of tooth movement and how much of the PDL is actually engaged at a certain time, there's an optimum force level that we should be striving for in order to get that light force, to get that frontal or direct resorption. So in the following slides, the loading diagram or area of compression will be shown by this red highlighter. The application of force and the direction of that force will be shown by this red arrow. So let's go through a bunch of different types of tooth movement. So the first one is uncontrolled tipping. This means that the crown goes in the direction of the force and the root goes in the opposite direction. So the heaviest pressure is felt at the root apex, opposite the side of where the force is being pushing the tooth, and the crest of alveolar bone on the other side is also feeling the heaviest pressure. So this is most commonly done in most of our tooth movement. If we're using a finger spring on an appliance, we're using brackets with round light wires. We'll talk more about specifics of all those things in the following video. But here we're just focusing more on the biological elements at play. So we'll talk more about specifics of center of rotation and center of resistance in the next video. So the ideal uncontrolled tipping force is about 50 grams if we want to maintain that light force threshold. As a shortcut, you can remember that about 50% of the PDL on one side of the tooth is being loaded in this type of movement. Now for controlled tipping, the tooth is being partially tipped but also partially translated. So what that means is the crown is again being tipped in this direction, but the root apex doesn't tip back the same amount as it would in uncontrolled tipping. This root apex stays a little bit more stationary. So as a result, more of this side of the root is being pushed up against the PDL. The ideal controlled tipping force is about 75 grams. And we can use our nice handy shortcut because about 75% of the PDL is loaded on this one side of the tooth. For bodily movement, the crown and the root equally move in the same direction. So this is pure translation. The crown and the root are being moved at the same rate so that this tooth is staying completely upright in the same orientation. The socket is just being remodeled like this to the side of the force application. So the entire PDL area is loaded, so there's equal compression all along this one side of the root. That's what I showed you in this first slide here. So that was an example also of bodily movement. The ideal bodily force is 100 grams. And again, if we go back to our nice shortcut, we can remember that 100% of the PDL is loaded on that one side. Now for root torque, this means that the crown barely moves and the root is actually moving in the direction of the force. This requires some more advanced biomechanic techniques like providing couples and using rectangular wires or auxiliaries, and again we can talk more about that in the next video. But even though the force is being applied in this direction, we're trying to keep the crown in a pretty steady position, and the root is what's doing most of the movement. So the ideal uprighting force for root torque is about 75 grams. Again, we can remember that about 75% of the PDL, and this is all pretty rough estimations, but about 75% of that PDL is being loaded. For rotation, that's simply talking about rotation of a tooth about its long axis. Now, it's a little bit more confusing because we're not just pushing the tooth one way or the other, we're just twisting it in its socket. So it's going to compress areas similar to what tipping would see due to an irregularly shaped root. So what this means is no root is perfectly conical. So if we were to twist a perfect cone, we would be engaging all parts of the PDL uniformly around the tooth socket, but that's not the case because every tooth has some amounts of irregularities. So as a very rough estimation, about 50% of the PDL is being compressed or stretched on any given one side. So you can remember that as being 50 grams of ideal force to provide the optimum amount of pressure to maintain a light force and frontal resorption. For extrusion, this refers to pulling a tooth gently out of its socket. And this is similar to rotation. Again, if it was perfectly uniform, we'd be engaging all parts of the PDL. Since all roots are somewhat irregular in shape, we're going to estimate that about 50% of the PDL is being compressed, and so the ideal extruding force is again around 50 grams. And lastly, we have intrusion. This is referring to pushing a tooth gently into its socket. This type of tooth movement requires exceptionally light force applied down the long axis of the tooth so that the PDL is compressed just at the root apex. the ideal intruding force is incredibly light at about 10 grams because very little, a very small area of PDL is being compressed in this type of tooth movement. And for that reason, it can be particularly challenging to do correctly. So for each of these type of movements, again, there's an optimal force experienced by the PDL depending on how much area of that PDL is being compressed at a given time. And notice that all of these numbers are 100 grams or less. So they ideally would classify as light pressure, although that is very difficult to achieve in orthodontics. Unfortunately, heavy force is a lot more commonly seen, and undermining resorption is somewhat unavoidable in terms of most treatment plans that you're going to expect to get undermining resorption during most of the treatment. And the last consideration is force duration. So here again we have time on the x-axis, but this time it's hours instead of days like we saw in the last graph. And again we have tooth movement on the y-axis, but this time it's in percent efficiency instead of distance in millimeters. So similar axes but different conditions. The threshold for tooth movement is around 4 to 8 hours. So this is really interesting. 4 to 8 hours is the absolute minimum because that's how long it takes for those cyclic AMP levels to start increasing high enough to lead to the PDL inflammatory response. Otherwise, we short circuit the process and then have to restart again from that seconds, then to minutes, and then to hours. So this is why patients need to wear their rubber bands, their Invisalign clear aligners, etc. for long enough time each day. Otherwise, they'll short circuit the biology. For any appliance that requires compliance, they need to be worn for enough time every day to get the most biological impact. And now you know why. So let's talk a little bit about force decay. There's no such thing as a perfect spring that exerts the same amount of force 24 hours, 7 days a week without some amount of decay over time. It's natural for every material to tire out over time. So the closest we can get to a perfect spring is what we would call continuous force. This force that's maintained at some appreciable level from visit to visit every time the patient comes in. So during an entire activation cycle, it's between appointments, although the force declines somewhat, that's what this graph is showing. So they come in, we activate the appliance, it's going to decline until we see them again for reactivation. But the appliance provides enough force during that time on the tooth to elicit a biological response for that entire duration. And then at the next appointment, the appliance is reactivated, new ligatures are put on, everything feels tight again, and the original force level is achieved once again. So this would be a prime example of a light wire. Now, interrupted force decays much faster than continuous force, as you can see in these graphs. And mostly that's because of the material composition. Here we were talking about metal, now we're talking about elastomeric rubber, which decays a lot faster and eventually, given enough time, will hit zero force. Interestingly, within about 24 hours, you're already going to lose about 50% of the force exerted by a stretched elastic chain, for instance. So this is where we generally can get away with heavier forces because once it relaxes to 0 grams, that gives bone necessary time to heal and repair and then get ready for the next session of undermining resorption. And finally, we have intermittent force. This is that which abruptly decays to 0 when the patient takes out the appliance. So great examples of this are rubber bands and clear aligners. When they put them back in, the curve will resume back where it left off, and based on how fatigued the material has become. Otherwise, it follows a similar pattern of force decay. So really, really interesting stuff there about thinking about how the material will tire over time, and in the case of compliant appliances, how the patient decides to wear them, how often per day they're putting those things in. So we've talked about the natural response, the biology that's going on in the periodontal ligament in response to certain pressures that we can apply. Now we can also get a little bit fancy and mess with the inflammatory response in order to get faster tooth movement. This is known as regional acceleratory phenomenon. So the name kind of talks about what it's all about. Regional is referring to inflammation at both the cut site and the adjacent bone. So this whole phenomenon relies on the fact that if we can aggravate the regional area where the teeth are moving, if we can literally go in there and make cuts in the bone, we can agitate and start to kickstart that inflammatory response and make it work faster. And that's what acceleratory is talking about. We're getting an intensified bone response due to agitated inflammatory mediators. So mediators like interleukins are going to be floating around the area where these holes are being made and activate those biological cascades quicker. On the left is called propel. It's where you make little holes in the bone through the gum tissue. It's actually fairly commonly used today in cases where the patient or the provider may want faster tooth movement. On the right is a more aggressive approach called periodontal accelerated osteogenic orthodontics, or Wilcodontics, which involves performing a full thickness flap, doing selective alveolar corticotomies, these little holes in cortical bone, and then placing a particulate bone graft over that, closing the flap, and then immediately applying orthodontic force. Both of these are examples of regional acceleratory phenomenon. So we haven't talked yet about the side effects of orthodontic forces. So we should be aware of some deleterious effects from moving these teeth around. And generally, more and heavier force correlates with more of these deleterious effects. So tooth mobility is a common side effect, and it's not uncommon for all teeth undergoing orthodontic treatment to be temporarily more mobile during that treatment. And this makes sense because the bony sockets are actively remodeling and the PDL is actively regenerating and moving about. So it's actually common to see widened PDL spaces if you take a progress panoramic during your orthodontic treatment. It's a little bit hard to see in this smaller image, but these PDL spaces are noticeably widened. This is an example of controlled inflammation. This is something that's under our control and we expect that to happen, but periodontal disease, traumatic occlusion, and clenching and grinding habits would make things much worse. That's why we never want to do orthodontic treatment on someone with active periodontal disease, because then we're going from sterile necrosis and controlled inflammation to what can become quickly uncontrolled inflammation. Periodontal pathogens are getting involved and things can quickly spiral out of control. So again, whenever we can avoid it, we want to get a stable periodontal condition before undergoing orthodontic treatment. Pain is another side effect that we expect. The PDL is undergoing ischemia and necrosis because some amount of heavy force in certain areas of the PDL is unfortunately unavoidable. We're getting bone remodeling, so there's going to be some amount of discomfort even with light force, but light force will generally have lesser pain and it won't be quite as immediate. You'll get more of a sore feeling within a few hours of the wires being tightened and having the appliance reactivated. Acetaminophen is generally recommended because drugs like aspirin and ibuprofen inhibit the formation of prostaglandins, which are needed for our orthodontic tooth movement. So chronic use of aspirin and ibuprofen can actually slow this movement down. Inflammation is usually the result of a poor oral hygiene. That's plaque being stuck under and between the brackets and the gums becoming red and swollen. It's rarely from a nickel allergy. The pulp can also be affected in some rare cases. Loss of vitality is only a concern for teeth with a history of trauma, extensive restorations, or if teeth are being moved over long distances with unusually heavy forces. Root resorption is another common side effect, but it's typically to a microscopic amount, and it's not a clinically relevant amount of root resorption. This is because the cementum adjacent to hyalinized PDL can undergo some amount of resorption of those clast cells that are being recruited. This occurs in about most every patient, but again, to some microscopic degree. In only about 3% of patients is this a clinically relevant amount of resorption. Risks for this amount of increased resorption include heavy forces, larger defects, apical defects. So this means that resorption that's occurring for a larger area or more apical area of the tooth do not repair themselves as well. Every tooth that's being moved is going to get some amount of resorption, but the tooth can repair itself unless there are larger defects that are forming or they're more apically located. Genetic factors can play a role. If you have something like short root anomaly, a single root is more prone for root resorption as opposed to a multi-rooted tooth. In teeth subjected to trauma, bruxism, and heavy masticatory forces, and movement of the tooth into that dense cortical plate. Whenever we can stay in the medullary bone, that's better. Dense cortical plate, if we're pushing a tooth up against that for a long period of time, that root will potentially experience a lot more root resorption. Mobility and longevity of a tooth that undergoes root resorption is not generally compromised as long as the marginal periodontium stays healthy. All right, so that's it for this video on the biology of tooth movement. Thank you so much for watching, everyone, and I hope you enjoyed it as much as I did putting this all together. So please like this video if you liked it and subscribe to this channel for much more on dentistry. If you're interested in supporting this channel and what I do here, please check out my Patreon page. Thank you to all of my patrons for all of their support. You can unlock extras like access to my video slides to take notes on and practice questions for the board exams. So go check that out. The link is in the description. Thanks again for watching, everyone. I'll see you in the next video.